طيب ممكن تبدأ على بركة الله إن شاء الله.
طيب بسم الله الرحمن الرحيم. The motor system, we are going to select the most important topics because it is very long and we are expected to answer questions after that. So this will be a very quick overview. We'll start with the reflexes immediately. I'm going to skip all very simple topics. So starting with the reflexes, better to know first that according to the receptor, because the reflex consists of receptor, afferent, center, efferent, and effector. You know that. According to the receptor, reflexes are classified into superficial reflexes, deep reflexes, and visceral reflexes. Superficial reflexes.
بروفيسور طارق، آسف للمقاطعة. أنا فاتح معك في الكور. لو عايز أي دياجرام أو فيجر أو أي حاجة في الكور you can tell me، وأنا لأنه I'm sharing my screen.
خير إن شاء الله. يعني همشي سريع على كل التوبكس تقريبا او معظم التوبكس ما كلها، وعشان داير زمن للام سي كيوز. فانا شغال في الريسبتور ناو. الريسبتور اللي هي صفحه 350 يا عم، انا بادئ من صفحه 350. طيب قلنا according to the site of the receptor we classify the reflexes into superficial, deep and visceral. This is important information because for example superficial reflexes like withdrawal reflex, abdominal reflex, plantar reflex, here the receptors are found in the skin. That's why it is superficial reflex. When you talk about withdrawal reflex, it is a superficial reflex. By a mistake it is mentioned as deep reflex later in this book, so you can correct this mistake. Abdominal reflexes, for example, you scratch on the abdomen, so the receptors are found in the skin of the abdomen. It is superficial reflex. Plantar reflex, superficial reflex. Deep reflexes, the receptor is found deep within the muscle, like stretch reflex. Stretch reflex, muscle spindle is found inside the muscle, so it is deep. That's why it is known as deep reflex. Also, Golgi tendon reflex, which is inverse stretch reflex, also the receptor is found within the tendon of the muscle, so it is deep. That's why it is deep reflex. Visceral reflexes like micturition reflex, defecation reflex, the receptor is found in the viscera. So if the receptor is found in the internal organs, then it is known as visceral reflex. So this is according to the receptor. This is important information. Another important information is classification of the receptors according to the number of synapses in the spinal cord. For example, in the spinal cord we have a stretch reflex. The synapse is a single synapse, so it is a monosynaptic reflex. A single synapse is there. Inverse stretch reflex is a bisynaptic reflex. Withdrawal reflex is a polysynaptic reflex. So when we talk about stretch reflex, it is a deep monosynaptic reflex. Deep because the receptor is found deep, monosynaptic because there is only synapse in the spinal cord. Inverse stretch reflex, it is a deep bisynaptic reflex because the receptor is found deep in the muscle, in the tendon, and there is two synapses. Withdrawal reflex is a superficial because the receptor is found in the skin, and polysynaptic reflex because there are multiple synapses in the spinal cord. So that's very important to know the example of each type of reflex, and then we will talk about the stretch reflex itself. Stretch reflex, the receptor is the muscle spindle, also known as intrafusal fiber, found within the muscle. You have to know that, and you have to read about the muscle spindle consisting of nuclear bag and nuclear chain and the description of each type. Okay, not very important, but you have to go through that. And the afferent is 1A. 1A neuron, this is the primary sensory ending. The primary afferent is 1A. As you know, we classify the neurons into A, B, C, and A is further divided into A alpha, A beta, A gamma, A delta. You remember that. But there is another classification into Roman numbers 1, 2, 3, 4. And 1 is further divided into 1A and 1B. So 1A is equivalent to A alpha. 1A is a rapidly conducting neuron known as 1A. Okay, so 1A is the type of afferent for the muscle spindle. So when they ask you about which type of afferent for the muscle spindle, it is rapidly conducting neuron type 1A, which is thick myelinated neuron. And also there is another afferent neuron for the muscle spindle type 2. This is known as secondary sensory ending. So there are two types of afferent from the muscle spindle, 1A and 2. The fibers of 1A wrap around the muscle spindle fibers, usually in annulospiral ending. And type 2 flower spray ending. This is not important, but sometimes questions may be related to that. If they are asking about annulospiral neuron, that means they are talking about 1A. If they are talking about flower spray neuron, they are talking about type 2. Okay, but the major information is that 1A is the primary sensory ending and 2 is the secondary sensory ending. This is the most important. The center is one synapse between 1A and directly the motor neuron, the efferent. So there is direct synapse between the afferent and the efferent, a single synapse. And usually the neurotransmitter is excitatory neurotransmitter here, because not like the inverse stress reflex, because there is interneuron which is inhibitory. There is inhibition in the inverse stress reflex, but in the stress reflex there is excitation. Direct synapse between 1A and the efferent neuron. And the efferent neurons are two types also. There are A alpha and A gamma. And here the information is important. A alpha because it supplies the extrafusal fibers, the muscle from outside. And A gamma will supply the muscle spindle again, but not in the center, at the end. The afferent comes from the center of the muscle spindle, but the efferent, A gamma, will supply the terminal end of the muscle spindle. This is very important. Ammar, can you go to page number 354? 354? 354.
I'm there. I'm following you. I'm there.
The picture there, 354. Okay, so as I mentioned, the efferent are two types, A alpha and A gamma. I mean the picture, Ammar, it is above this. Above this immediately there is a, yes, exactly. Okay, so you can see here the afferent comes from the center. Okay, this is the primary afferent, the annulospiral, okay, coming from the center of the muscle spindle, but the efferent will come from the terminal end. A gamma, the motor ending, as you can see, the motor ending comes to the terminal end of the muscle spindle. So when A gamma discharge comes to the muscle spindle, usually the muscle spindle is stretched. So A gamma is going to cause a stretch of the muscle spindle, and this is the stimulus for this reflex. That's why it is known as a stretch reflex, because you stretch the muscle spindle. And usually the muscle should be stretched from outside. Okay, if you are stretching the muscle from outside, that means you are stretching the muscle spindle inside. That's the main way of stretching. But there is another way of stretch, by the A gamma discharge, because the A gamma discharge is going to cause contraction of the terminal end of the muscle spindle, and this will stretch the central part, resulting in activation of the muscle spindle. This is very important. We can activate the muscle spindle by stretching the whole muscle or by increasing the A gamma discharge. After stretching the muscle, the afferent will cause stimulation of the efferent, and the efferent will cause contraction of the muscle from outside. This is the muscle spindle reflex. But why A gamma discharge is important? Because normally at rest, there is tonic discharge from A gamma. That means there is tonic contraction in the muscle spindle without stimulation, without stretch. A gamma is going to stimulate the muscle spindle, and accordingly the stretch reflex will result in mild contraction of skeletal muscle. So all our muscles at rest there are slight degree of muscle contraction caused by A gamma discharge. This slight degree of muscle contraction is known as the muscle tone. The muscle tone is a slight degree of muscle contraction. Whenever you try to move that muscle passively, usually you will find resistance to passive movement. This resistance to passive movement is known as the muscle tone. What generates the muscle tone? A gamma discharge. Now we know A gamma discharge will generate the muscle tone. If there is hypertonia, that means A gamma discharge is more than normal. If there is hypertonia, that means A gamma discharge is less than normal. If there is normal tone, that means A gamma discharge is normal. Okay, so that's the first very important thing to know. And accordingly, we have to know the clinical application of the stretch reflex. A gamma discharge is normally inhibited by descending tracts from the brain. So if there is damage above the level of the spinal cord, above the level in the segment of the spinal cord where the motor neuron is going to come out, if there is damage at that area, this will result in loss of inhibition. Again, there is inhibition by descending tracts. Spinal cord transection will result in loss of inhibition. A gamma discharge will become, will lose the inhibition, so will increase. If there is damage to the spinal cord, A gamma discharge will increase. Okay, so this will differentiate between upper and lower motor neuron lesion. I expect you to know something about that. You know, corticospinal tract, the main motor tract. Corticospinal tract from the cortex to the spinal cord is the main motor tract descending from the spinal cord. The corticospinal tract consists of two main neurons. One neuron originating in area 4 in the brain, in the cerebral cortex, and the axons will descend through the brain stem, through the medulla in the biomets, and will descend to the spinal cord until they reach the efferent of the muscle spindle, A alpha neuron. And then the A alpha neuron will go out of the spinal cord to supply the muscle. So there are two neurons. One neuron in the brain and spinal cord, and the other neuron from the spinal cord will go out to supply the muscle. There are two neurons. The first neuron is known as the upper motor neuron, and the second neuron is known as the lower motor neuron. If the damage is in the spinal cord or the brain, it is known as upper motor neuron lesion. If the damage in the second neuron, the damage is known as lower motor neuron lesion. So again, upper motor neuron lesion means there is damage in the brain or spinal cord, because this damage will affect the upper neuron. It is known as upper motor neuron lesion. Lower motor neuron lesion, the damage to the peripheral neuron, the spinal nerve outside the spinal cord. If there is damage to that nerve, that means it is lower motor neuron lesion. Accordingly, let's talk about the stretch reflex now. We know that A gamma discharge will create the tone in the muscle. If there is upper motor neuron lesion, the neuron that inhibits the muscle spindle, inhibits the A gamma discharge. Okay? If there is damage to that neuron, A gamma discharge will increase and will result in hypertonia. That's why upper motor neuron lesion is characterized by hypertonia. If the damage in the peripheral neuron, that means the damage affects the A gamma discharge itself. The A gamma neuron itself and the A alpha neuron are affected. And this will result in lower motor neuron lesion characterized by hypotonia or loss of tone. Okay, so this we have to know the difference between upper motor neuron lesion and lower motor neuron lesion. Okay, I will mention them, and then okay, we are going to answer questions related to them. Upper motor neuron lesion characterized by hypertonia, hyperreflexia, okay, and abdominal reflexes, loss of abdominal reflexes. Better to open the page, which is describe all these signs: hypertonia, hyperreflexia, loss of abdominal reflexes, extensor plantar response, we call it positive Babinski sign, plus the paralysis or paresis that occurs due to damage of the motor neuron. Okay, lower motor neuron is characterized by hypotonia, areflexia, there is no reflexes, wasting of muscle, fasciculation, but fasciculation usually occurs early in the lesion, not long-standing lesion. Usually recent lesion will result in fasciculation. And it is not related to the plantar response or not related to the abdominal reflexes, okay? Only loss of tone, loss of reflexes, wasting of muscles, fasciculation, these are the main signs. You have to memorize this and you have to be ready for any questions related to that. Again, upper motor neuron lesion is characterized by, in addition to the paralysis, both of them, upper and lower, will result in paralysis or paresis, weakness. But the main signs are hypertonia, hyperreflexia, absent abdominal reflexes. Yeah, that means superficial reflexes are absent, and extensor plantar response. Okay, plus usually the wasting is not found in no wasting or minimal wasting in upper motor neuron lesion. Okay, opposite in the lower motor neuron lesion, there is hypotonia, hyperreflexia, there is wasting of muscle, okay, gross wasting in muscles, and in addition to that, as I mentioned, there is fasciculation. Fasciculation usually occurs in the recent lesions. This is about the stretch reflex and its application in medicine. Okay, less important is inverse stretch reflex and withdrawal reflexes. They are less important. You have to know in the inverse stretch reflex that it is bisynaptic reflex, deep reflex, bisynaptic reflex. Al-afferent is not 1A, it is 1B. And the synapse is not a single synapse, two synapses, because there is interneuron and the interneuron is inhibitory. So the stimulus will be overstretch and the response will be relaxation of muscle. So in a stretch reflex, you stretch the muscle will contract. This is the stretch reflex. In the inverse stretch reflex, you stretch the muscle with force, overstretch, and then the muscle will relax. Okay, this is the inverse. That's why it is inverse stretch reflex. Withdrawal reflex, painful stimulus will result in contraction of muscles, usually contraction of the flexors and on the same side, and extensors on the other side. Contraction of the flexors on the same side to get away from the painful stimulus, and contraction of the extensors on the other side to support the body. Okay, so you can think about it and you can see photos about withdrawal reflex to understand that. So these are the main information you have to know about reflexes. Which reflexes are superficial, which are deep, which are visceral, which are monosynaptic, polysynaptic, bisynaptic, and the afferent in stretch reflexes is 1A, in inverse stretch reflexes is 1B. This is monosynaptic, excitatory, will result in contraction of muscles. This is bisynaptic, inhibitory, will result in relaxation of muscle. Stretch reflex is stimulated by stretch. Inverse stretch reflex is stimulated by overstretch. And the efferents in the stretch reflex are A alpha and A gamma. A alpha to the extrafusal fibers to cause contraction, and A gamma to generate muscle tone. A gamma discharge is controlled by descending tracts. Some of the tracts will increase A gamma discharge, like the cerebellum, for example, and some tracts will inhibit the A gamma discharge. Okay, and usually upper motor neuron lesion will result in certain signs, and lower motor neuron lesion will result in other signs. Okay, we revise that. Okay, we can go quickly to another topic, important topic, before answering the questions. Okay, we can go to basal ganglia. Okay. Spinal cord transection, already we talked about it last time. Okay, if there is a spinal cord transection, usually the patient will go through 3 phases: 2 weeks, 2 weeks, and then after 4 weeks. Okay, the first 2 weeks is known as spinal shock. So after the spinal cord transection, usually the complete transection, usually the patient will get into spinal shock. In spinal shock, there is loss of tone, loss of reflexes. Is it upper or lower motor neuron lesion? If there is transection of the spinal cord completely, that's upper motor neuron lesion or lower motor neuron lesion. Which of them, Shabam? Anyone to answer?
Upper motor neuron lesion.
Is it
Upper
upper
motor.
or lower?
Upper.
Yes, exactly. It is upper motor neuron lesion. But in spite of being upper motor neuron lesion, there is hypotonia, hyporeflexia, plus the paralysis. So there are signs of lower motor neuron lesion, but the lesion is upper motor neuron lesion. This stage is known as spinal shock or neuronal shock, because the neurons suddenly will lose the upper motor control and therefore they will get into shock. But after 2 weeks there is retention of reflexes, and usually the reflexes, when they return back, they return higher than normal. So there is hyperreflexia, but after 2 weeks. This hyperreflexia usually starts in the visceral reflexes before the tendon reflexes. So micturition reflex, defecation reflex will return back, and then after that we have the tendon reflex, biceps reflex, knee jerk, ankle jerk. All these reflexes will return back after 2 weeks. After another 2 weeks, that means after 1 month, there is the tone will return back. The tone. So first the reflexes will return without the tone. Then after that the tone will return back, and the patient will get into extensor contraction. This phase is known as extensor contraction. So there are 3 phases: spinal shock for 1 to 2 weeks, then retention of reflexes, okay, and then after 3 to 4 weeks there is extensor contraction. And now you know the phases of the complete transection of the spinal cord. Below the level of the lesion, there is loss of tone, loss of reflexes, if it is spinal shock. But after that, there is hypertonia, hyperreflexia, after retention of reflexes, and extensor contraction. Okay, so signs of upper motor neuron lesion will appear below the level of the lesion. But if there is hemisection of the spinal cord, half of the spinal cord is cut, then the phases will appear in one half, not the 2 sides, into one side of the body. And if you remember, there is characteristic sensory loss. Usually there is loss of dorsal column tract on the same side and spinothalamic tract on the other side. And you remember dorsal column tract sensations which are lost: fine touch, vibration, position sense, 2-point discrimination, like that. And pain and temperature on the other side will be lost. So we discussed that last time. So this is about the spinal cord transection, complete transection and hemisection. This is the most important information, by the way. And then we can go to the pyramidal tract. Already we talked about the 2 neurons, the upper neuron and the lower neuron, and the details of that tract you have to read about. Okay, it is not important for physiology, but for anatomy it is very important. And usually we ask about the clinical associations. Usually in the nervous system in physiology, we ask about the clinical part, not the anatomical part. So we come to the basal ganglia. The basal ganglia, the structures you have to know: the caudate, glutamate, and globus pallidus, and the related structures, subthalamus and substantia nigra. These are the structures of the basal ganglia. Okay, quickly I'm going through it so we can answer the questions. And the connections of the basal ganglia also usually we don't ask about the details, but we have to know certain tracks. For example, here, if you can look at page number 379, the picture there, 379, yes, this one. Okay, you can look at this picture. Okay, in this picture you can see the connections in the basal ganglia. As you can see, the cerebral cortex is going to excite the corpus striatum. Okay, so the corpus striatum is excited by glutamate and acetylcholine. And lower down, under the corpus striatum, you can see substantia nigra. Substantia nigra will inhibit the corpus striatum by dopamine. That's known as nigrostriatal pathway or dopaminergic neurons. These dopaminergic neurons, if lost, the patient will develop Parkinson's disease. So this is the damage. So Parkinson's disease will occur if there is damage to substantia nigra, or if there is damage to the nigrostriatal pathway, loss of dopaminergic neurons. When dopaminergic neurons are lost, the corpus striatum will become excited by acetylcholine, not inhibited by dopamine. It will become more excited by acetylcholine. So there is more excitation. That's why it will send more inhibition to the globus pallidus, especially the internal structure, the internal segment of the globus pallidus through the direct pathway. Through the indirect pathway, as you can see here, the corpus striatum will inhibit the external segment, and the external segment will inhibit the internal segment. So if there is more excitation, that means there is more inhibition of the external segment, and this will result in loss of inhibition on the internal segment. So the internal segment will become excited more, will be inhibited, by the direct pathway from the corpus striatum, which is more excited to inhibit the internal segment more. Okay, so internal segment, then its effect on the thalamus will be reduced. So the thalamus will excite the cerebral cortex, and this will result into the features of the Parkinson's disease. Just for you to understand, all these connections are inhibition by GABA. As you can see, corpus striatum is inhibiting the internal segment by GABA, and the external segment by GABA. The subthalamus, okay, also it will inhibit the subthalamus by GABA. I mean the globus pallidus is inhibiting the subthalamus by GABA, and the globus pallidus is inhibiting the thalamus by GABA. So GABA is inhibitory neurotransmitter from the corpus striatum to the globus pallidus, and from globus pallidus to the thalamus and subthalamus. But the globus pallidus itself is excited by glutamate, as you can see from the subthalamus, by glutamate. And the corpus striatum is inhibited from substantia nigra by dopamine. So the questions mainly they ask about inhibition and excitation. Okay, which of these structure will send excitatory neurotransmitter? Which of them will send inhibitory neurotransmitter? You have to know that. And definitely, you have to know the most important, which is dopamine from substantia nigra to the corpus striatum. Dopamine for inhibition of the corpus striatum. And to the corpus striatum by acetylcholine. Why? Because treatment of Parkinson's disease depends on that. Parkinson's disease usually is treated by giving anticholinergic. You can give anticholinergic because corpus striatum is losing dopamine. You can give dopamine, okay, or you can stop acetylcholine. Okay, these are the two options for treatment of Parkinson's disease: giving dopamine, or in form of L-DOPA, or stopping acetylcholine by giving anticholinergic drug for treatment of. Okay, so this is the most important. Other important feature in basal ganglia is the functions of the basal ganglia themselves. they are involved in planning and programming of movement. So planning and programming of movement is not only the function of the cerebral cortex, the frontal lobe, the prefrontal area, it is also a function of the basal ganglia, and it is a function of the lateral part of the cerebellum. So lateral part of the cerebellum is involved in planning and programming of movement. Basal ganglia is involved in planning and programming of movement. Also, it is involved in initiation of voluntary movement. Okay, and that's why in Parkinson's disease there is failure to initiate movement. Okay, so there is no paralysis, although Parkinson's disease is known as paralysis agitans, but there is no paralysis. There is just failure to initiate the movement. And a lot of associated movement like swinging of the upper limbs while walking, this is lost in the Parkinson's disease. Inhibition of muscle tone, so extrapyramidal tract inhibits the A gamma discharge. Okay, so inhibition of muscle tone is very important from the extrapyramidal tract, and that's why damage to the basal ganglia, that means loss of inhibition, it will result in hypertonia. Okay, so remember the hypertonia, one of the features of Parkinson's disease. Cognitive function also through the caudate nucleus, this is also one of the functions of the. So you have to know the functions, because in physiology you have to know functions of each structure. So functions are important for you. And then features of Parkinson's disease. Features of Parkinson's disease are a triad. You know the triad of Parkinson's disease are tremor. Tremor usually, the tremor of Parkinson's disease is resting tremor. Okay, hypertonia. The hypertonia in Parkinson's disease is rigidity. As we mentioned, hypertonia is caused by A gamma discharge. If the A gamma discharge is increased to the flexors and extensors together, it is known as rigidity. So hypertonia in agonist and antagonist muscle. If hypertonia comes to one group, to the flexors without extensors, it is spasticity. So the difference between rigidity and spasticity is very simple difference. Spasticity is hypertonia in one group, flexors or extensors. And usually it occurs in spinal cord transection. Spinal cord transection will result in spasticity. In basal ganglia lesions, usually hypertonia goes to the agonist and antagonist muscle. So it is rigidity, not spasticity. Hypertonia, which type? Rigidity. Okay. Hypertonia also is described as clasp knife, lead pipe, and cogwheel. Clasp knife, because usually when you examine the hypertonia, you hold the upper limb of the patient and then you try to flex and extend. While you are trying to flex, if there is resistance, this is hypertonia. If the resistance is throughout the whole range of movement, smooth resistance, that's lead pipe. If the resistance occurs initially and then there is no resistance, that means the resistance at the start of flexion, and then there is no resistance, is known as clasp knife rigidity, hypertonia. Usually this is spasticity. This clasp knife is spasticity. Okay, lead pipe is rigidity. And if the resistance is interrupted resistance, occurs with interruption, so there is resistance, no resistance, resistance, no resistance, like that, is known as cogwheel rigidity, and it is rigidity. So again, hypertonia, three types: clasp knife, usually spasticity in spinal cord transection; cogwheel, usually rigidity; and lead pipe, usually rigidity. So in Parkinson's disease, the hypertonia is rigidity, not clasp knife, lead pipe or cogwheel rigidity. These two types. Okay, it should never be clasp knife, because clasp knife occurs only in spasticity. And the tremor, as we mentioned, usually resting tremors. When the patient at rest, the tremors will appear. When the patient starts to move, usually the tremor will disappear. That's different from cerebellar lesion. Usually in cerebellum, there are intention tremors. That means when the patient at rest, there are no tremors, but when the patient intends to move, usually the tremors will appear. So it is movement tremors or kinetic tremors in cerebellum. But in Parkinson's disease, it is akinetic. Akinetic means without movement, resting tremors. The third feature of Parkinson's disease is akinesia. Akinesia means poverty of movement or no movement. Akinesia, that means the kinesia, which is the movement, is not existing. And this appears in, for example, the expression of the face. There is no movement of the muscles of expression in the face, and that's why the patient will have mask face. While walking, there is no movement of the upper limbs, no swinging of the upper limb while walking. That means this is akinesia. So the akinesia usually appears here, okay? And when the patient intends to move, to initiate movement, usually there is failure to initiate movement. There is delay in the initiation of movement, and that's also a form of akinesia. So akinesia, which will appear in different features, rigidity, which is hypertonia, cogwheel and lead pipe, and tremor, which is resting tremor, disappears with movement. In case scenarios in the questions, usually they depend on these features when they design the case scenario for you. For example, when they say like that, the patient 65-year-old, usually Parkinson's disease occurs in old people. 65-year-old man came to the outpatient clinic complaining, for example, of any complaint, not necessarily neurological complaint, and the doctor noticed tremors in the hand. So the doctor noticed tremors while the patient is sitting. That means it is resting tremor. If it is associated with other features, you go immediately to Parkinson's disease. In other case scenarios, they mentioned that the patient is complaining of something, and when he, for example, points or moved or something like that, the doctor noticed tremor. So the doctor noticed tremor when the patient stretched his hand to hold something. That means it is intention tremor, and this will point to cerebellar lesion. So from these observations, usually you can reach the diagnosis, whether it is basal ganglia lesion, Parkinson's disease, whether it is cerebellar lesion, like that. One of the features of Parkinson's disease is, okay, these are the features. Other features, shuffling gait, okay, and stooped mask face, as I mentioned, decreased blinking, very common in questions usually. Decreased blinking, it is very important. And loss of associated movement, failure to elevate the lower limb while walking, shuffling gait, as I mentioned, and difficulty in writing, micrographia. Usually because of the hypertonia, usually they have difficulty in writing, and usually because of the hypertonia also, the handwriting size will be very small. There is micrographia, they cannot write big letters, only small letters. Drooling of saliva, anxiety, depression, all these are features of Parkinson's disease. And as I mentioned, the treatment is dopamine in form of L-DOPA. Why in form of L-DOPA? Because dopamine cannot cross the blood-brain barrier. So you have to give the precursor of dopamine, which is L-DOPA. L-DOPA can cross the blood-brain barrier, and within the brain, it can be converted to dopamine to exert the effect. But because L-DOPA is converted peripherally into dopamine before going through the blood-brain barrier, you have to combine it with any substance that prevents peripheral decarboxylation, which is carbidopa. So L-DOPA plus carbidopa together, you give them. So carbidopa will prevent conversion of DOPA to dopamine until DOPA goes through the blood-brain barrier and enter inside to treat Parkinson's disease. Also, as I mentioned, anticholinergics, because the corpus striatum, if you remember, is losing the inhibition by dopamine. So it is overexcited by acetylcholine. You give anticholinergic to treat the excitation. So you will restore the balance after giving this drug. So these are the modalities of treatment. Surgery is also tried, but no good results. That's all. For the other abnormalities of basal ganglia, you have to know the structure which is affected. This is the most important actually. For example, for chorea, usually the damage in the caudate nucleus. It is very easy when you remember chorea starts with C, caudate nucleus starts with C. So chorea, caudate nucleus. Sometimes they mention corpus striatum, okay, because corpus striatum means the caudate plus putamen together. This is the corpus striatum. So if the corpus striatum is affected, that means the caudate is affected, and this will result in chorea. So if they mentioned chorea is caused by damage to the corpus striatum, it is correct. Chorea is caused by damage to the caudate nucleus, that's correct also. So chorea is a dancing movement. You have to know the description. But the most important information is which structure is affected. Acidosis is caused by damage to the globus pallidus. So acidosis, globus pallidus, caudate, chorea, globus pallidus acidosis, and hemibalismus subthalamus. Remember it like that. Hemibalismus, balismus or hemibalismus. Usually is caused by the subthalamus or damage to the subthalamus. This will result in hemibalismus. Usually balismus and chorea are associated with hypotonia, while acidosis is associated with hypertonia. This is also important because some questions are related to that. So acidosis with hypertonia, hemibalismus and chorea hypotonia, and now you know the structures which affect each of them. As I mentioned, I am talking about the most important information because the questions are related to this area. The motor system is very huge and very complex. It needs a long time to read. You can read it in throughout your study, but these are the most important areas you have to concentrate on. The cerebellum, also you have to know the clinical part of the cerebellum. The anatomical divisions of the cerebellum, anterior, posterior, and folliculonodular lobe. Okay, this is important for anatomy. For physiology also, we have you have to know the functional divisions because the function of each division is related to physiology. Folliculonodular lobe is known as vestibulocerebellum because it is connected to the vestibular apparatus, and so it is responsible for equilibrium, balance and equilibrium. So vestibulocerebellum, folliculonodular lobe for balance and equilibrium. Questions will come like that. Which of the following areas of the cerebellum or structures is concerned with or responsible for equilibrium or balance? And different parts is spinocerebellum, cerebrocerebellum, and vestibulocerebellum. So vestibulocerebellum or folliculonodular lobe responsible for balance. Spinocerebellum is the vermis and the adjacent medial parts of the hemisphere. Usually the vermis of the cerebellum and the medial part are very important parts of the cerebellum, and as you can see, spinocerebellum. That means from this area the efferent will go to the spinal cord. There is connection to the spinal cord and coordination here. The main function is coordination. And for new cerebellum or cerebrocerebellum, these are the lateral parts of the cerebellar hemisphere. Usually the lateral parts are concerned with planning and programming, if you remember. Okay, planning and programming of movement. So cerebrocerebellum is well developed in humans, unlike the animals, and as I mentioned, it is very important for planning and programming. That's why it has connections with the cerebral cortex. These are the most important. The deep cerebellar nuclei are dentate, globose, imbuliform, vestigial. Okay, and the cells that affect or interact with these deep cerebellar nuclei are 5 types of cells. All of them are inhibitory, except one type, granular cells, excitatory. This is one information also important, and the neurotransmitter is GABA for inhibition. So Purkinje cells are inhibitory, basket cells are inhibitory, Golgi cells are inhibitory, stellate cells are inhibitory. Only granular cells are excitatory. And granular cells are found in the deep layer there are 3 layers in the cortex of the cerebellum. Okay, the deep layer is known as the deep granular layer. The middle layer is the Purkinje cell layer, and the superficial molecular layer, it contains other types of cells. Superficial cells, usually stellate and basket cells, are found superficially. Middle layer, there is Purkinje cells. Okay, and deep granular layer, this is the excitatory cells, the only excitatory cells which will send the parallel fibers. Usually you hear about parallel fibers. Parallel fibers come from the granular cells and they excite the Purkinje cells. Purkinje cells receive climbing fibers. Usually the climbing fibers, usually the input to the cerebellum comes through climbing fibers and mossy fibers. Climbing fibers come from the medulla, and usually they excite the Purkinje cells. And mossy fibers, usually they affect the deep granular cells. Okay, mossy fibers, they affect the deep granular cells. You can see the connections here from page number. Yes, this is this picture. Okay, you can see the deep cerebellar nuclei, and you can see the 3 layers of the cortex. The upper layer, superficial molecular layer, basket cells and Golgi cells. Purkinje cell layer, this is Purkinje cells, and deep granular layer, granular cells. The granular cells usually, as you can see, they will give parallel fibers. Parallel fibers will excite cells of the superficial molecular layer, basket cells and stellate cells, and also dendrites of Purkinje cells are excited by the parallel fibers. Other cells, as I mentioned, all of them are inhibitory, including the Purkinje cells. And the Purkinje cells are the only cells that inhibit the deep cerebellar nuclei. So the inhibition comes only from the Purkinje cells to the deep cerebellar nuclei. Other cells are not affecting the deep cerebellar nuclei, only the Purkinje cells. But the mossy fibers and the climbing fibers can excite the deep cerebellar nuclei. These are the input from outside. From inside, only Purkinje cell can affect the deep cerebellar nuclei. From outside, mossy fibers and climbing fibers can excite the deep cerebellar nuclei. Mossy fibers can excite also granular cells, and climbing fibers can excite also the Purkinje cells. So generally, these are the connections you have to know about the cerebellum. Functions of the cerebellum are very important. Coordination of voluntary movement. This is very important because the brain, whenever it sends any motor order, it will send a copy of the motor plan to the cerebellum, and the cerebellum already receives proprioception, position sense. So the cerebellum has idea about the position, and he has idea about the required or intended movement. So it will coordinate the movement and will exert what's known as braking effect. Braking effect, that means it will stop the movement exactly in the area required. That's known as the braking effect of the cerebellum. And based on the braking effect, there are certain tests we are going to talk about, how we are going to test for the braking effect of the cerebellum. And also it can increase the muscle tone, so the effect on A gamma discharge is to facilitate the A gamma discharge. Unlike the basal ganglia, they inhibit the A gamma discharge. The cerebellum will facilitate the A gamma discharge. So it is responsible for balance, folliculonodular lobe for balance, and it is also direction of movement. All these are the features of the cerebellum. And cerebellar ataxia, the signs are very important. You have to know them. Signs of cerebellar ataxia: drunken man gait, which is wide-based gait and steady gait. Usually they walk like a drunken man, and there is nodding of the head, yes, yes movement or no, no movement. And there is nystagmus. Type of nystagmus is horizontal nystagmus. This is in the cerebellar ataxia. Dysarthria, usually defective speech. Tremors, and as I mentioned, it is intention tremors or kinetic tremors. Okay, akinetic tremors in basal ganglia, kinetic tremors in cerebellum. Bus pointing, this is loss of the braking effect, bus pointing, and it is tested by finger nose test. We ask the patient to just to point the tip of the finger of the doctor and his nose. But when the patient points at the tip of the finger of the doctor, usually he points at a distant area. So he will pass the tip of the finger, pass pointing. So the point will be passed by the finger of the patient. This is known as dysmetria or bus pointing. Also, because he will lose the braking effect of the cerebellum, as I mentioned. Also, there is a test of diaduchokinesia. Diaduchokinesia is the ability to do rapid alternating movement. This diaduchokinesia is failure to do the rapid alternating movement. So patient of cerebellar ataxia usually has this diaduchokinesia or a diaduchokinesia. That means he cannot do rapid alternating movement like supination and pronation very quickly. So he cannot do supination and pronation repeatedly, and this indicates cerebellar ataxia. Also hypotonia, because as I mentioned, the tone will be facilitated by the cerebellum. If there is no cerebellar, there is cerebellar lesion, there is hypotonia, rebound phenomena, it's also loss of the braking effect. Usually you ask the patient to flex his upper limb, forearm. While flexion, you are holding it as a resistance. So he's flexing his upper arm against resistance, his forearm, I mean, against resistance. While flexing, you suddenly release your resistance, then immediately he will touch the tip of his shoulder because he cannot stop it before hitting the shoulder. Better not to do it across or opposite the face, because if it's done opposite the face, he will immediately hit his face. So you do it opposite the shoulder, so he will hit the shoulder. This is known as rebound phenomena, and it is due to loss of the braking effect of the cerebellum. Decomposition of movement and difficulty in swallowing, all these are also signs of cerebellar ataxia. Control of posture, I don't know whether you studied that or not, because in some universities they skip this topic. Can you tell me whether you studied control of posture or not? Writing reflexes, hopping reaction, like that. Have you studied that?
Rowan.
Yes.
Okay, that's good actually. So control of posture, what is needed? Usually you have to know that the control of posture consists of many reflexes at different parts of the body, studied in experimental animals after doing transections at different parts of the neural axis. So usually in the spinal cord, for example, there are certain reflexes to control the upright position. These reflexes are important for the posture, and they are stretch reflex and inverse stretch reflex and positive supporting reaction, negative supporting reaction. These are integrated in the spinal cord. You have to know which reflexes are integrated in which area. These are the spinal cord reflexes. But the difficulty comes in the reflexes which are integrated up. For example, there are certain reflexes which are integrated in the cerebral cortex, and certain reflexes which are integrated in the medulla or the bones or the like that. So we will start with the lesion which is at the superior border of the bones. If the experimental animal, in some experimental animal, we do a lesion at the superior border of the bones. In humans, usually it may occur by severe lesions, and it is incompatible with life. The patient will die after very limited time. He will die quickly. But in animals, they may survive and they may move sometimes in spite of these lesions. So control of posture can be studied in these animals. One of the lesions actually at the superior border of the bones, that means above the medulla. This will result in decerebrate rigidity. You have to know where is the lesion and what's the effect. So at the superior border of the bones, decerebrate rigidity. In decerebrate rigidity, which is spasticity, not rigidity, but it is known as decerebrate rigidity, usually it will result in extensor response. Usually the patient will develop extension. And yes, as you can see, this decerebrate rigidity, you can see there is extension in all limbs. This is decerebrate rigidity, and it will allow study of medullary reflexes. This is the decerebrate rigidity. Another, so it will result in rigidity and it will result in extension of limbs. In the superior, and it will allow a study of medullary reflexes. At the superior part of the midbrain, also still it will result in extension, okay? But decerebrate rigidity, similar to decerebrate rigidity. But above the bone, above the midbrain, above the red nucleus, it will result in decorticate rigidity. Above the red nucleus, that means encroaching to the cortex or damage to the cortex itself. So there is loss of the cerebral cortex. This will result in decorticate rigidity, and here usually there is flexion in the upper limb with extension of the lower limb, but mainly there is flexion in the upper limb, and this is known as flexure position, which is decorticate rigidity. Okay, and usually the midbrain reflexes can be studied in these patients. So decorticate is the other picture in which there is flexion in the upper limb, and decerebrate extension in all limbs, decorticate flexion. In that one the damage is above the bones. In this one, in decorticate, the damage in the cerebral cortex. So in the cerebral cortex itself, above the red nucleus, above the midbrain, but above the red nucleus itself. So it will result in this decorticate rigidity. And as I mentioned, you have to memorize the reflexes. So in the spinal reflex, we have a stretch reflex, withdrawal reflex, positive supporting reaction, negative supporting reaction. The names of the reflex are enough, I think, because all these reflexes, the receptors are found in the muscles. So, and the integration is found in the spinal cord. So these reflexes will control posture, but they are integrated in the spinal cord itself. I put here a picture of a neonate. In the neonates, as you know, the brain is not well developed. So the neonate is similar to a patient with damage to the upper areas. So upper centers, as if there is damage. There is no damage, but there is no development. And that's why these reflexes appear in neonates. After they become, during childhood and during adulthood, they will disappear. The same reflexes in the same neonate will disappear because the neural tract will become well developed and there is inhibition from upper centers on the lower centers. But these primitive reflexes can appear in the neonate and can be studied also in the neonate because of the less development of the upper centers in the brain. That's why the positive supporting reaction is very clearly, you can see positive supporting reaction and negative supporting reaction in these neonates. So medullary reflexes, you have to memorize the names also. There is tonic reflexes in the medulla, tonic labyrinthine reflex and tonic neck reflexes. Tonic labyrinthine reflex, that means whenever you do any movement in which the labyrinth is the inner ear. So the otolytic organ in the inner ear is usually is excited by movements in the horizontal plane or in the vertical plane. If this movement horizontally or vertically occurs, it will result in movements to adjust the posture. But usually it cannot appear in human. You cannot see the exact reflexes unless there is damage, as I mentioned, above the level of the medulla at the superior border of the bones in the decerebrate rigidity. So as you can see in this picture, when you put the child with decerebrate rigidity into supine position or prone position. Usually there is flexion and extension accordingly. So placing in the supine position will result in extension, as you can see here, or in the prone position will result in flexion, as you can see in the picture also. And this is known as tonic labyrinthine reflex, which is integrated in the medulla. And tonic neck reflex also integrated in the medulla and the receptors in the neck muscles and the neck proprioceptors. And usually when you move the head to one side, okay, there is extension on that side you are looking at and flexion on the other side. Okay, so this is tonic neck reflexes. So two reflexes in the medulla, tonic neck reflex and tonic labyrinthine reflex. Mid-brain reflexes are known as writing reflexes. Usually you will find this word, writing reflex. It is mid-brain reflex. As I mentioned, in the decorticate animals, you can see that labyrinthine writing reflex. Writing reflex means correction of the body position. Usually, if the body position, for example, if you put the head lower than the body, the head should be elevated so as to correct the posture. If you have, for example, a cat, and you put the head of the cat lower down, you can find that the cat is trying to elevate her head up to correct the position up. Okay, so this is known as the writing reflex, and it is integrated with the midbrain. There are different writing reflexes: labyrinthine writing reflex, body on head writing reflex, body on body writing reflex, neck writing reflex, vestibular blessing reaction. All these are midbrain reflexes. The only writing reflex which is integrated in the cerebral cortex is the optical writing reflex. Okay, optical writing reflex, that means the correction of the body according to vision, and you know the optic nerve usually is integrated in the occipital lobe, so in the cortex, in the cerebral cortex. So anything related to vision, it is integrated in the cerebral cortex itself. So this optical writing reflex. It is one of the cerebral cortical reflexes, not midbrain. Midbrain reflexes are writing reflexes, but the only writing reflex which is integrated in the cerebral cortex is the optical writing reflex. We have also placing reaction and hopping reaction. Usually with displacement, the animal or the human will jump so as to correct his position, and this is known as the hopping reaction. Integration of this reflex is in the cerebral cortex. So postural reflexes usually are complicated, and usually we ask about the place of integration more than the contents itself. So I expect the same for you. You just try to memorize which reflex is integrated in which area in the neural axis. So very quickly we finished talking about the motor system. Now we can start to solve the questions. Who will come with me today? Tigani or another one? Anyone wants to volunteer?
We need a volunteer, guys.
I can do it.
We'll go quickly, and we will not.
One volunteer, Prof. Tarig will help you with answers. Rawan Badikir, Rawan Awokar.
Thank you, Rawan. Don't worry. Inshallah, it will be very easy and we'll go very quickly. Don't worry. And
Okay.
I will help. Type. Now, first question about upper and lower motor neuron lesion. I will revise the signs again. Upper motor neuron lesion, if you remember, we mentioned hypertonia, hyperreflexia, absent abdominal reflexes, extensor plantar response. Lower motor neuron lesion, we mentioned hypotonia, hyperreflexia, wasting, and fasciculation for recent lesion, not for long-standing lesion. Okay, so now let's start to talk about the question. Long-standing lower motor neuron lesion is characterized by, they mentioned long-standing lower motor neuron lesion. Okay, clonus True or false?
False.
False. Clonus, Rawan, is upper motor neuron lesion sign. It is also
Yeah.
related to the hyperreflexia. So hyperreflexia,
Yeah.
which occurs in upper motor neuron lesion, clonus is similar to that. Actually, we have ankyloclonus and plantar clonus, and usually it is a maneuver. Depends on the maneuver you examine the reflexes. Fasciculation.
False.
Why false? Fasciculation is lower motor neuron sign, but why false? You are correct.
Yes, but you
Because
said
it is,
now that it's, yeah.
yes, it is long standing. Yes, because they said long standing. That's why it is false. Extensor plantar response?
False.
False. Upper and wasting?
True.
Yes, this is the true, and rigidity is false. So the correct answer is wasting of affected muscle. All questions about upper and lower motor neuron signs in the CNS physiology like this. Okay, and it is very easy to pick the correct answer if you're wrong. So now we go to the gamma motor discharge. You remember the gamma motor discharge? We mentioned that gamma motor discharge will generate the muscle tone, and it is affected by descending tracts. So we didn't mention all of them. Okay, we mentioned few of them. Let's see now which of them will excite, which of them will inhibit. So I will answer this question for you. Motor area 4, the cerebral cortex usually inhibit. Okay, excite, facilitate. Cerebellum facilitate. Vestibular nuclei facilitate. Medullary reticular formation inhibit. Okay, pontine reticular formation facilitate. So the gamma motor neuron is inhibited by medullary reticular formation. Actually, this question is very important, because usually if we are going to ask you another question similar to this, all information is found here. Okay, pyramidal tract or motor area 4, this will result in facilitation, cerebellum facilitation, vestibular nuclei facilitation, medullary reticular formation inhibition, pontine facilitation. I can add basal ganglia inhibition also, if you remember. Okay, so very important to know the answer of this question. The spinal shock phase of complete spinal transection is characterized by, yes, Rawan, can you answer this question? Spinal shock.
It's characterized by areflexia.
Areflexia. There is a mistake that areflexia should be one word. Okay, there is no space between A and R. Areflexia. Okay, that means there is no reflexes, and because the spinal shock, 1 to 2 weeks of no reflexes, no tone, no movement, nothing below the level of the lesion. Okay, that is correct. Thank you. So the muscle spindle. Question number 4. The muscle spindle. We remember the muscle spindle. The receptor is 1A. Okay, and 2. And the synapse is a single synapse, if you remember. And the efferents are A alpha and A gamma. Okay, this is the muscle spindle, the stretch reflex. So the muscle spindle is the receptor of inverse stretch reflex. True or false?
False, because the receptor for the inverse
of the
reflex is the Golgi tendon.
Okay. Can you remember the name of the receptor for the inverse stretch reflex?
The Golgi tendon organ.
Excellent. I didn't mention today, yes, but I think you are prepared already. If I know you are prepared, I will decrease many of the information. So, yes, Golgi tendon organ is the receptor for inverse stretch reflex. Correct. Very good. It's supplied by A alpha motor neuron.
False.
By A gamma motor neuron. A alpha motor neuron will supply the extrafusal fiber, the whole muscle. But the muscle spindle itself is not supplied by A alpha, it's supplied by A gamma. Excellent, very good. Results in relaxation of extrafusal fiber in response to overstretch.
That's also the inverse.
That's the inverse stretch reflex. Overstretch will result in relaxation. Is it stimulated when extrafusal fibers contract?
No.
When extrafusal fibers is stretched.
Yes,
Okay?
stretched.
So the muscle spindle is stimulated by stretching, not by contraction. You are correct. And is stimulated by gamma motor discharge?
Yes, that's the correct answer.
Yes. So the muscle spindle is stimulated by two ways, as I mentioned, by A gamma discharge or by stretching of the whole muscle. Okay. Question number 5. The following statements about Renshaw cells are correct, except Renshaw cells are very important cells actually for negative feedback of A alpha discharge. A alpha discharge, the motor neuron, when the motor neuron is going to cause contraction of the muscle, it should not, usually the response should be the target response. Okay, and the information about Renshaw cells is found here. All these are correct information about Renshaw cells. Okay, because I didn't mention, I will just mention the information. They are inhibitory interneurons. Renshaw cells are inhibitory interneurons, correct? They are found in the gray matter of the spinal cord. Yes, they are found in the ventral horn of the spinal cord, the anterior horn of the spinal cord, with the A alpha. So A alpha going out of the anterior horn cell, anterior horn of the spinal cord, and Renshaw cells are found there also. It will excite the Renshaw cell, and the Renshaw cell will inhibit it. Okay, so it is negative feedback. Excited by collateral from A alpha motor neuron, yes, it is excited by collateral from A alpha. Representative of negative feedback mechanism, yes, it is representative of negative feedback mechanism. Cholinergic neuron, this is the incorrect, okay, information. Because it is inhibitory, that means it should not release acetylcholine. It will release glycine, for example, to inhibit. So it is inhibitory interneurons. This is the incorrect, and it is the selected answer because they said except. So all are correct except this. The question number 6, Rawan, the muscle spindle is not stimulated by stretch.
False. It is stimulated by stretch.
Well, stimulated by stretch. Is not innervated by 1A.
False. It is innervated by 1A, our friend.
Yes, excellent. Is covered by a connective tissue capsule.
False.
Yes, it is covered. Tamam. Acting, so it is true, but it is false. Acting
yes, exactly.
as a receptor of a deep reflex.
Wrong, because it does act as a receptor of a deep
true,
reflex.
but it is false, not that, because we are asked about not the negative. Found in tendons of muscle.
Yes, this is the correct answer, because it's not
This
found in tendons of muscles.
Because it is false, it is found in the substance of muscle, not the tendon of muscle. Okay. Number 7, the following is a polysynaptic reflex. Which of these is a polysynaptic reflex?
The withdrawal reflex.
Withdrawal reflex. Very good. Excellent. Withdrawal reflex. Okay. So we go to the inverse stretch reflex. It is caused by stimulation of 1A.
It's false.
By 1B.
That's
yes.
yes.
Caused by stimulation of alpha motor neuron.
False.
False. Okay. And caused by inhibition of alpha motor.
Yes, exactly.
Induced by overstretch of the muscle tendon.
This is the true one, correct?
This is the correct answer. So it is protective. It is against excitation, overexcitation, monosynaptic reflex. Okay. It is protective against overexcitation of the muscle spindle, not the muscle spindle, overstretch of the tendon. Okay. So this is incorrect. And monosynaptic, it is bisynaptic.
It's a bisynaptic, yeah.
Yes, exactly. In a lower motor neuron lesion, there is exaggerated abdominal reflexes.
It's hypotonia.
Yes, and abdominal reflexes should be absent. Abdominal reflex is a superficial reflex. Usually in superficial reflexes in upper motor neuron, sorry, we are talking about lower motor neuron, not upper motor neuron. In lower motor neuron lesions, usually the abdominal reflexes are not affected or absent. they can be absent. Okay. Also, if the afferents or efferents are involved in upper motor neuron lesions, they should be absent because the damage is above the lesion. Above the lesion, the afferent and efferent are not affected, but it is absent. In lower motor neuron lesion, they can be present and they can be absent, but they can never be exaggerated. Okay, they can never be exaggerated, and they will be absent only if there is involvement of the afferent or efferent. This is for the abdominal reflexes, superficial reflexes. Hypotonia in the lower motor neuron lesion of the question. This is the correct answer. There is hypotonia. Persistent fasciculation?
No.
Yes, there is fasciculation, but it will occur in the first few days of the lesion. Minimal muscle wasting?
No, it's maximal.
Yes, exactly. And hyperreflexia?
No, it's hyporeflexia.
Exactly. Very good. Excellent. Now this question, if you are following well, cogwheel rigidity is a feature of? Which of these is a cogwheel rigidity is a feature of?
Parkinsonism.
Excellent. So rigidity is found in Parkinsonism, and it can be led by or cogwheel, but spasticity is a feature of pyramidal lesions. Spasticity, spinal cord transection, okay? Sorry, spinal cord transection. And rigidity, Parkinsonism. Very good. Type, question number 11. Parkinson disease is characterized by which of these?
Bradykinesia.
Yes, bradykinesia or akinesia. There are triad. Can you remember the triad? The triad is rigidity, tremor, and akinesia. Rigidity, tremor, and akinesia. This is a triad. Okay. Is there any muscle wasting in Parkinsonism? Is there any muscle wasting? Sir, Miss
No.
Muscle wasting, there is no muscle wasting. Is there any weakness? Also, there is no weakness. Although it is paralysis agitans, but there is no weakness. Okay. What about kinetic tremors? Why it is incorrect? Rawan, kinetic tremors, why it is incorrect?
I'm not sure. I can't remember.
It should be a kinetic tremor, not kinetic tremor. Kinetic tremor, that means movement tremors. Movement tremors is found in cerebellar lesion. A kinetic tremor is found in, okay. We go to acetosis. Is caused by damage to? Acetosis is caused by
Globus pallidus.
Excellent. Globus pallidus. Balismus, subthalamus. Caudate, chorea. Okay. Substantia nigra, Parkinsonism. Okay. Tamam. The following does not occur in Parkinson disease.
Because they all do occur.
So clonus cannot occur in Parkinson disease. Clonus. Mask face is there, rigidity is there, tremor is there, akinesia is there. Okay. 14. Chorea occur due to damage to
Caudate nucleus.
Caudate nucleus. C. Caudate nucleus. Excellent. The following is not basal ganglia structure.
1 second. Question hasn't loaded for me yet.
Okay. The following is not a basal ganglia structure. The correct answer is thalamus.
Thalamus.
Yes. Usually subthalamus is correct, but thalamus is not part of the basal ganglia. Okay. Which of the following is characterized by muscle paralysis? Okay. Muscle paralysis usually here occurs in syringomyelia. Anyone remember anything about syringomyelia?
No.
Syringomyelia, if you remember the central canal. Do you know the central canal in the spinal cord?
Yeah.
Yes. The central canal will be dilated when the central canal is congenitally dilated with cerebrospinal fluid, and the fibers of the anterolateral tract, usually the fibers of the spinothalamic tract, will come near the central canal. If there is dilation, these fibers are affected. So the touch, the crude touch, and the pain and temperature will be lost. But fine touch, position, sense, 2-point discrimination of the dorsal column tract will be intact. Okay? The motor fibers also will be affected by dilatation of the central canal. So in syringomyelia there is muscle wasting, features of muscle wasting, okay, and muscle paralysis, because the fibers are affected while they are going from there, and there is dissociated sensory loss. Dissociated sensory loss. Dissociated sensory loss, if you remember, intact fine touch and loss of pain and temperature in one side of the body. Okay. So this is syringomyelia due to dilatation of the central canal and affecting the motor fibers and sensory fibers. So we have sensory and motor signs in the limbs of the patient. Usually it occurs in the cervical area. That's why the hands and the upper limbs are affected more than other parts of the body. طيب, cerebellum, there is no muscle paralysis. Parkinson's, there is no muscle paralysis. Hemipalismus, and no muscle paralysis. And vestibular damage, no muscle paralysis. Only syringomyelia. Acidosis is caused by damage too. Again, it's the same question.
D. Globus pallidus. We just did it.
Globus pallidus.
Pallidus, yes.
Yes. The following represents a spinocerebellar lesion or function. Spinocerebellar. We mentioned spinocerebellum. Which of these? Answer is?
Coordination of voluntary movement.
Yes, exactly. Coordination. So spinocerebellum for coordination. Vestibulocerebellum for balance. Okay. And we have the third new cerebellum for planning and programming of thought. Cerebellar lesion result in which of these?
C.
C. Dysmetria. This is direct. As we mentioned, we are testing this with finger nose test. Dysmetria. So there is past pointing or dysmetria. Micrographia is a sign of Parkinson's disease. Exaggerated reflexes, upper motor neuron lesion. Muscle wasting, lower motor neuron lesion. Resting tremor, Parkinson's disease. So remember each sign. The stretch reflex is which of these?
It's C because it's bisynaptic and deep, and it's not exaggerated in lower motor neurons.
Stretch reflex. We are talking about question number 20.
Yes, it's integrated in the spinal cord.
Yes, integrated in the spinal cord. Yes, very good. Question number 21. All the following abnormalities are characterized by tremors, except tremors. Maybe resting tremor, maybe fine tremor, maybe intention tremor.
Is it? I'm not sure actually. I just know there's tremors in stress, hyperthyroidism, and cerebellar diseases.
Yes,
but I'm not
stress,
sure about.
Definitely. Hyperthyroidism, there is also tremors. Okay. And substantia nigra, this is Parkinsonism. And cerebellar disease, there is tremors. So subthalamic lesion. Okay. So subthalamus, hemipalismus, there is no tremors. The optical writing reflex. Optical writing reflex is integrated.
It's integrated at the cerebral cortex, and it's the only writing reflex at the cerebral cortex.
The only writing reflex which is not integrated in the midbrain. Okay. The stretch reflex is, again, same question. Repeated.
D. Exaggerated. Sorry. I'm waiting for it.
So let's go one by one. Polysynaptic?
No, it's not. It's
Visceral reflex?
No, it's a deep.
It is deep reflex. Integrated in the brainstem?
No, it's integrated in the spinal cord.
Usually in the spinal cord. Absent in the lower motor neuron lesion?
No. This is it is absent actually, sorry. It's absent in lower motor neuron lesions.
This is the correct answer. Integrated in the brainstem may be correct because sometimes they have somatic, some of the cranial nerves, they have somatic fibers supplying some muscle, but this is more correct. Absent in the lower motor neurology is straightforward. This is the correct answer. It is found in children, of course. Which of the following is a medullary postural reflex? Medullary. Medulla.
It's the tonic labyrinth reflex.
Exactly. Tonic neck reflex and tonic labyrinth. So it is very easy. That's postural reflexes are very easy. The following does not occur in Parkinson's disease.
Kinetic tremor, because it's akinetic.
Yes, because it is akinetic, it should not be kinetic. A lesion at the superior border of the bones in experimental animal will result in all the following except
E.
Okay, so superior border of the bones, if you remember, will result in decerebrate rigidity. Okay, and decerebrate rigidity will allow appearance of medullary reflexes, not midbrain reflexes. So appearance of writing reflexes is incorrect. Okay, so all are correct except E, appearance of writing reflexes. The deep cerebellar nuclei are directly inhibited. Which cell will directly inhibit the deep cerebellar nuclei?
The Purkinje cell.
Yes, Purkinje cells. Which of these cells mentioned is excitatory? So Purkinje cells are inhibitory, Golgi cells are inhibitory, granular cells are excitatory, multifibers
granular.
Most of them also are excitatory. Okay, so we have three kind of excitatory, Purkinje cells and other cells, basket cells, stellate cells, all these are inhibitory as I mentioned. The only cells in the cerebellar cortex are granular cells, excitatory, plus these climbing and multifibers. This area of questions also, which of them is excitatory, which of them inhibitory. Okay, by this question, thank you, Rawan, thank you very much. By this question, actually,
thank you,
we
Prof.
hope new information you were able to grasp from this very quick description of the motor system. For being very quick, but the time will not allow elaborated discussions. Inshallah, maybe I can find a better time to discuss more. And thank you for following, and see you inshallah next time inshallah.
شكرا يا بروفيسور.
شكرا يا دكتور.